Hey, good morning, everybody. Welcome to today's webinar, the microbial party in your pipes. It's not just Legionella anymore. I want to introduce our speaker, Dr. Janet Stout, president and founder of the Special Pathogens Laboratory and research associate professor at the University of Pittsburgh's Swanson School of Engineering in the Department of Civil and Environmental Engineering. An infectious disease microbiologist, Dr. Stout is recognized worldwide, that's all over the world, for over 30 years of pioneering research in Legionella. Her expertise includes disinfection and control strategies for the prevention of Legionnaire's disease and other waterborne pathogens, which is why we have honored Dr. Stout as our very first Healthy Buildings hero, hosting these three critical webinars. Before we begin, I'd like to inform the audience to please feel free to submit questions throughout the event via the Q&A or the chat function feature, as well as our speaker will leave some time at the end of the presentation to address questions. Any technical questions you may have, we'll address as soon as possible in the chat. And now, without any further ado, I'd like to turn over today's presenter. Go ahead, Dr. Janet Stout.
Thank you so much, Greg, for that kind introduction. I'm going to share my screen now so we can begin. So thank you so much, Chicago Faucets, for the opportunity for all of us to be together to talk about my favorite subject, the microbial party in the pipes. It's not just Legionella anymore. And as Greg said, you know, I have this affiliation with the University of Pittsburgh Swanson School of Engineering in addition to the Special Pathogens Laboratory. So I always like to give a little shout out to my colleagues that are continuing to do the research, and I'm involved in those projects as well. So you benefit from that affiliation. So I am an infectious disease microbiologist, and I have been studying Legionella for more than 30 years. And what I usually say about that is that I'm not an infectious disease microbiologist anymore. I'm a Legionellologist. Okay, yeah, I did make that up. But it sort of adequately and accurately describes my career. So my mission today with you is to share what I've learned, not only about Legionella, but other waterborne pathogens. And so it's not just Legionella anymore. There's growing awareness that these pathogens in our water distribution systems are potential disease risks, especially in the healthcare environment. So we want to prevent these infections too. And what we do is we really turn to some fairly recent changes in direction from the Center for Medicare and Medicaid Services, the Joint Commission. So healthcare facilities need to know about these waterborne pathogens. And then how do you detect them in water? And I'm going to tell you some sort of secrets so that you know and can avoid mistakes in terms of detecting these pathogens. And then water management and water safety and sampling for these pathogens needs to be part of that overall water safety and management plan. So we're going to begin today by taking a little microbiology tour. And this is my emoji, End Legionnaire's disease, Dr. Stout. And we're going to take a little tour. And we're going to start our tour when we talk about the millions of bacteria in our pipes. And so on the left is the GI tract, or the pipes inside our body. And what we call those billions of bacteria in our GI tract, we call it a microbiome. And then on the right are the pipes in our buildings. And when we talk about the billions and billions of bacteria in the plumbing system, we talk about biofilm. So think about a slime layer all along the miles and miles of pipes in our buildings, in our healthcare facilities. So what are they doing in there? They're having a party in the pipes, right? Those microbes are having a good time in there. Well, you might be going, well, who's there? Who's at the party in the pipes? So here's a very nasty faucet that I found some years ago. So I took a picture of the underside of that, and you can see it's really covered with that biofilm. And the organisms, the bacteria that are present there, are Stenotrophomonas multifida, Acinetobacter, Pseudomonas aeruginosa, and bacteria that actually multiply inside protozoa and amoeba, Legionella, as well as an organism called non-tuberculous mycobacteria. So we're going to talk all about these today. But first I wanted to give you kind of an icky example of what we're talking about here. So a drop of water was placed on these two culture plates, and these plates are designed to grow Klebsiella and Enterobacter, and the one on the right, Pseudomonas aeruginosa. Well, you can see these plates are covered by those bacteria. Well, where did that specimen come from? The water in a medical intensive care unit faucet. This was the water we collected from that faucet. I saw these culture results and I was shocked. So I hope that you are too. So just imagine those healthcare workers going over there and putting their hands under that water, just getting doused with these waterborne pathogens. So be careful about putting your hands under those faucets. And I would recommend waiting for that water to flow through for a while, not using that water immediately. So we're going to start by talking about sort of a really dramatic event that occurred in 2017 when the Center for Medicare and Medicaid Services, CMS, really out of the blue, came out with this memorandum to prevent Legionnaire's disease. And I was like, that is fantastic. So they wanted healthcare facilities to implement plans to reduce Legionella. And this is the part that's really surprised me. And other waterborne pathogens or opportunistic waterborne pathogens. I was like, well, okay, that sounds good. And so they want you to conduct first a risk assessment, and they want you to identify not only where Legionella can grow and spread, but these other waterborne pathogens as well. So this is now the responsibility of healthcare facilities. And again, they called out specific waterborne pathogens that we just talked about: Pseudomonas, Acinetobacter, Burkholderia, Stenotrophomonas multifida. I like to say that. Sort of sounds like you should be doing a kick dance, doesn't it? Stenotrophomonas multifida. And then non-tuberculous mycobacteria. So that was 2017. So then in 2018, about a year later, a revision to the memorandum came out. And we were like, well, what's this about? And it says revised to clarify expectations for providers. And basically in the first version, they said do environmental monitoring for these pathogens. And so this revision says, well, wait a minute, we've gotten some pushback about that. We're going to leave that to the discretion of the facility. But what remained was the requirement to conduct that risk assessment for waterborne pathogens beyond Legionella and to include that in the water management plan. So it wasn't just CMS. There was actually some more breaking news in the fall of 2020. Again, I kind of fell out of my chair when the Joint Commission came out with an announcement that they were going to be doing a public review because they wanted to do something to strengthen the requirements from the Joint Commission about water management. And so then they did that public review period in the fall, and in March of this year, they announced these changes are coming. They're actually going to do and introduce new environment of care standards. So this is big news to all healthcare facilities. So in this new environment of care, 0.2.05.02, the Joint Commission is proposing this new sort of strengthening the water management program for these different healthcare facilities. And what they're asking for is not all that new. It's still based on CMS and ASHRAE Standard 188. So they're not recreating something new. They're emphasizing and now making healthcare facilities more accountable. Now, showing you this EC 0.02.0502 reminded me, I wanted to tell you that you don't have to take notes feverishly during the presentation because I'm going to be going over information pretty quickly. You will receive a SlideShare link and a recording of this presentation, so you can relax. So in the Joint Commission instruction here with this new environment of care policy, again, it's not new. These are the elements of Standard 188. The organization has a water management plan, but I've highlighted here the difference between Standard 188 from ASHRAE, which deals exclusively with Legionella, Now the Joint Commission and CMS are adding other waterborne pathogens. And so similarly, you have to have a plan, you have to have a water safety and management program team. They're responsible for creating the flow diagrams and making sure that monitoring is conducted, as well as document, and then make sure that if there are corrective actions in the plan, that you do them and that you document that you've done them. And then there's a requirement for annual review. So again, annual waterborne pathogen risk assessment, establish that water management team, and hopefully most of you have done that to some degree or another. And that team, and the one thing that I want to emphasize here for healthcare is, in addition to engineering and facilities management, you must have input from infection prevention. They add a different perspective and knowledge, especially with waterborne pathogen risk. So again, you'd include patient safety, people that are actually on the ground doing the work, and you might have some consultants or water treatment providers. And you want to make sure that that plan describes what's happening with that water throughout your building, including the flow diagram and any specialty water systems like dialysis. Now, the Joint Commission said, don't worry, we're giving you fair warning. So these are the same facilities that are impacted. In July 1, people saw that these new requirements were coming. It was included in the manuals and the announcement that they won't be scored against them until January 2022. So you have some time to get your ducks in a row, so to speak. So why does CMS and the Joint Commission care about these other waterborne pathogens? Well, they care about them because they cause significant numbers of healthcare-acquired infections. They affect disproportionately the immunocompromised, and many of these organisms are antibiotic resistant. So if you prevent them from occurring, you worry less about the fact that people get infections that maybe we won't be able to treat. So when I think about these microbes and their antibiotic resistance, I sort of imagine X-Men. Well, maybe these organisms are X-bugs, so all of these that are listed here have a propensity for having antibiotic resistance. So that's one of the concerns from CMS. And then the other one is that these infections contribute significantly to overall healthcare costs. So this is a January 2021 publication in Emerging Infectious Diseases by a group at Center for Disease Control and Prevention, looking at the burden of these infections due to waterborne pathogens. So these are some alarming numbers: 7.15 million waterborne illnesses annually, almost 7,000 deaths, and then 3.3 billion in direct healthcare costs. And then when they broke it out, 2.4 billion, or 72% of the costs, were due to hospitalizations and deaths due to non-tuberculous mycobacteria, Pseudomonas aeruginosa, and Legionella. So significant healthcare costs. And then there's a number of publications that are available to you. This is also from the Center for Disease Control and Prevention, looking at healthcare-related outbreaks due to waterborne pathogens. So where are they happening? I mentioned the immunocompromised. So the majority of the infections are occurring in inpatient facilities, 70%, but also in outpatient facilities and long-term care. And in this study by the CDC, which pathogens were they seeing these infections occurring? Non-tuberculous mycobacteria, almost 30%. About 20% from Pseudomonas species, and then about 10% from Burkholderia species. And so this report did not deal with Legionella, so Legionella was excluded from this report, so that's why it's not listed here. Well, how is the exposure occurring from water to the patient? So the mode of transmission and to disease causation is that the organism has to be there, it has to get from the water to the patient, and it has to be a susceptible patient. So I highlighted some things by underlining here. Injection and medication preparation near sinks, so there's splash. Nutrition, breast milk, and infant formula prepared near sinks. Patient care supplies also stored by sinks and toilets, yikes. And then some medications and solutions are contaminated by water. In addition, dental unit water lines, bacteria love dental unit water lines. There's a nice little tiny, tiny heater in there that warms it up very nicely. And then use of tap water for rinsing equipment like bronchoscopies, and then using non-sterile water or tap water in humidifiers. They shouldn't be doing these things, but it happens. And then neonatal intensive care units. I'm going to kind of hammer that home today, but contaminated water in those sinks, contaminated water at scrub sinks in ORs, and then drains. You think there's a party in the pipes. Well, if you look down in the drain, it's even more so. It's like the Las Vegas of plumbing. And then, of course, dialysis is prone to bacteria growing there. And this one example is the dialysis wall boxes. And then ice. We all think water out of the tap is good for anything, including ice, but those bacteria can be in ice. And if that ice is used by immunocompromised individuals, there's a problem there. Well, one thing that's true about these waterborne pathogens is they're not normal flora in the body. They're usually found in water, and in the case of Pseudomonas and some others, in soil. And so long time ago, it was noted, don't bring vegetables and flowers into the hematology, oncology, and transplant unit because they're harboring waterborne pathogens like Pseudomonas. So the message here, if it's in the water, it's completely preventable by interrupting that chain of transmission. So if we keep the bacteria in the water away from the patient, we can prevent the infections. So this publication, Healthcare Outbreaks Associated with Water Reservoirs and Infection Prevention Strategies, talks about the risk in healthcare facilities. And it's the highest risk is those that are immunocompromised. And this list just tells you a number of the conditions. And then the one at the bottom, age. It's both the elderly and the neonate and preterm babies. They have increased risk for waterborne pathogen infections. So think about that when you're thinking about your water management programs. What's the target? The target is areas that serve these patients. Well, how is water used in healthcare? Lots and lots of different ways. I'm not going to read through this laundry list, but all kinds and manners of use of water in healthcare facilities. So water everywhere, not a drop to drink, but be careful how you use it. So how is it transmitted throughout the hospital water distribution system? So improperly reprocessing medical devices, using poor quality water for the immunocompromised, using poor quality water for NICU. Now, when they say poor quality, they're meaning tap water, water with bacteria, non-sterile water. And then improper use of tap water in respiratory care, preparing nutrition, breast milk and solutions for immunocompromised individuals. Again, improper oral care, that's the dental connection there. And then preparing injections and medications near sinks. So now we're thinking differently about that sort of innocuous sink there in the corner of the room. It's a potential place where transmission of infection can occur. And then water droplets and aerosolization from contaminated showers and toilets, and then splashes from sink drains. And so all of this relates eventually to how we prevent the infection. Now, one thing that's different about these waterborne pathogens from Legionella and actually non-tuberculous mycobacteria is that Legionella is just in the water. It's not in the body, it's not on the hands. So these other organisms can be transmitted by direct contact, through bathing, through healthcare workers' hands, through contaminated water being ingested, aspiration, especially in the elderly, and then exposure to aerosols. So there's multiple modes of transmission and sources when it comes to these other pathogens, including equipment that's used on patients. So there's a decision tree that has to be made when I'm going to be working with this equipment or managing this patient. Is it the correct water? Meaning, should I be using sterile water? And then follow the instructions for use from the manufacturer. Well, there's that confusion icon there because those instructions are often complex and nobody really reads them completely. And so it's hard for people to follow those instructions. We also have problems with shutdowns and low use and no use, especially during this last year with COVID. And I could give you a whole lecture just on construction and the impact of that on water quality. But let's just talk about shutdowns for a second. Why do these microbes like shutdowns, and what have we learned about it? And so what I say is, what's flow got to do with it, got to do with it? So when you have no flow, what happens with the bacteria? So I did a little experiment. So I want you to use your imagination here. So the vase here is the pipe, and the flowers in the vase are the nutrients that are in our pipes, and that's the sediment and corrosion byproducts. So I let the water flow in this vase over a 2 to 3 day period, and the water remained clear. In the other bottle, I stopped the water. I let the water be stagnant for the exact same period of time. And you can see how cloudy and murky that water is. Well, let's take a closer look. Ooh, now there's like a slime layer on top of the water. So this experiment shows that the bacteria in our pipes, given the nutrients that are readily available, and when the water stagnates, they multiply. So what's in your stagnant pipes? Well, I say there's a microbial party in your stagnant pipe. So this helps you understand why we're concerned about shutdowns, low use, delayed occupancy during construction. Because when that water stagnates, disinfectant residual disappears. When hot water isn't recirculating, its temperature goes down into that nice sweet spot for those bacteria to grow. And similarly, with cold water laying in those lines, the cold water warms up, again, right to the sweet spot for Legionella and these other waterborne pathogens to grow. So anything above room temperature, above 77, less than 110 is ideal for these bacteria to grow. So in order for whatever disinfectant's in the water to have an effect on these microbes, it has to pass through the pipe and through the fixture. If there's no flow, there's no disinfection. So the other thing that happens when that water stays in there is this term increased water age. So the water stays in there longer, and so it degrades the water quality. When that happens, Legionella and other bacteria have an opportunity to grow. And those bacteria, they work together synergistically, one helping the other to grow. So when those other bacteria grow, they can help Legionella to grow. And those rapidly growing bacteria, share nutrients, provide nutrients to each other to help them grow. So in case you've forgotten who we're talking about, non-tuberculous mycobacteria, Pseudomonas aeruginosa, Burkholderia, Acinetobacter species, Stenotrophomonas multifida, and other gram-negatives. So I'm going to just tell you, kind of introduce you a little bit more to each of our characters. So Pseudomonas aeruginosa is the most common waterborne pathogen in human specimens, can be antibiotic resistant, right? Causes a wide range of infections. And I want to introduce you to Sally, Pseudomonas. Yes, here we are. Sally has flagella. And Pseudomonas causes folliculitis, is one example of a skin infection, and ecthyma gangrenosa. And so I'm going to show you what this means. So it's all fun, all well and good in your hot tub. And this is sort of a public service announcement. Be careful about what hot tub you get into, because it could have Pseudomonas or Legionella in it. And what happens if it has Pseudomonas in it? Ooh, nasty rash. That's a rash caused by Pseudomonas aeruginosa called folliculitis. Now, if an immunocompromised patient gets a bloodstream infection with Pseudomonas, I'm going to warn you, this is really a gross picture, but it helps you to understand the severity of infections associated if Pseudomonas aeruginosa gets into the bloodstream of an immunocompromised person. So the skin infection is called ecthyma gangrenosum, mostly affecting immunocompromised people. So we want to prevent that from occurring at all. Now, I get up on my soapbox just a little bit when we talk about neonatal intensive care units, whether it's Legionella or Pseudomonas aeruginosa. There's lots of reports in the literature of Pseudomonas infections in neonates. So this is one of them in the Journal of Pediatrics and Child Health. Pseudomonas aeruginosa infections due to neonatal intensive care unit. This is a headline in Pennsylvania. 3 babies died of Pseudomonas infection, and the investigation indicated that it was sort of incomplete cleaning of their bottles that were used in the NICU. Now, I want to tell you now about something that we do here at Special Pathogens Laboratory. We have Puzzled by Legionella Wednesday webinar series. And we don't just talk about Legionella. And so we have spoken about Pseudomonas in the NICU, and Olga Guzman was the speaker. And you can go to specialpathogenslab.com and listen to that presentation, and a lot of good information there. And then there's other publications talking about sort of the plumbing and its relationship to Pseudomonas in premise plumbing. So at the bottom of this slide, I have prevalence of different faucet types, whether they were manual or electronic sensor faucets, and sink drains as being contaminated with Pseudomonas aeruginosa, and what that means to you in terms of maybe how you select different types of fixtures in your healthcare facility. So this is a free publication. So some journals are what they call open source. That means that you don't have to have a subscription to the journal. So if you go to Microbiology Open in your Google search and search for Pseudomonas aeruginosa, that article will pop up, and you can download that article for free. And free is really great. So in this publication, they talk about faucet design, and that faucet design should minimize the surface area where water comes into contact, prevent stagnation or accumulation of water in those fixtures, and what the impact is of the materials within the fixture, elastomers and plastics, and how they exude materials that some of these bacteria actually use to grow. So you can learn a lot from that publication and about the factors that promote Pseudomonas growth in our building water systems, flexible hoses, that stagnant water, temperature control at the fixture, and et cetera. So a really good article to read about Pseudomonas. Well, it's not just about Pseudomonas. There's other organisms, and these are all mostly gram-negative bacteria. This is a report in Pediatric Infectious Disease Journal about one of those organisms that CMS says pay attention to, Acinetobacter species. They found this organism in the sink and linked it to infections. And as I said before, these organisms can be highly resistant to antibiotics. So if infection occurs, it's really a challenge for the physicians to save the patient. So in this case, 13 patients, very young, from 1 month to 19 years, bloodstream infection, 10 out of 11 died. 85% mortality, very shocking. So we want to prevent these infections if at all possible. And again, they link the infections to contaminated sinks and tap water. Here's my favorite one. Remember, Stenotrophomonas multifida KIK. So it's actually used to be called Pseudomonas multifida. So it was renamed Stenotrophomonas, and it's a prolific biofilm producer. It's in water, it's on vegetables, it's in soil, it's intrinsically resistant to antibiotics, an important pathogen for the immunocompromised, and also for cystic fibrosis patients. They often get colonized and then ultimately have infections due to Pseudomonas aeruginosa. Mycobacteria, non-tuberculous mycobacteria. These are water organisms. They don't cause tuberculosis. That's why it's called non-tuberculous mycobacteria. Famously, a few years back, were linked to infections in cardiac patients, this particular species, Mycobacteria chimera. And just quickly, water is used in these heater-cooler devices. The water dripped down and was spread in the operative area by the fans. These heater coolers were contaminated at the industrial site of manufacture and then shipped all across the world, where these infections were noted in multiple patients all over, and then ultimately linked back to the manufacturer, who was testing the devices with tap water and infected the devices with Mycobacterium chimera. One of the challenges with non-tuberculous mycobacteria is they're highly highly resistant to disinfectants. And so this publication just talks about these mycobacteria species being 100 to 300 times more resistant to chlorine than E. coli. So the message is, don't rinse equipment in tap water, including tap water that has Legionella. So this was a publication back in 2003 where they were rinsing this device, a transesophageal endocardiography probe, in tap water that resulted in Legionella infection. So the key takeaway here is, don't rinse devices that have contact with patients in tap water. This includes colonoscopes, duodenoscopes, all kinds of scopes. And this was a particular outbreak of highly resistant E. coli and Klebsiella pneumoniae. And so it's really often linked to inadequate cleaning. They're very complex devices. I'm going to show you a picture as an example. Inadequate drying. And so all of these are covered within under infection control policies, but sometimes policies aren't followed. So you have to be careful about that. So this is an example of an endoscope, just showing you the complexity of them. Again, those instructions for use from the manufacturers give adequate instruction for cleaning, but oftentimes mistakes are made. And then sometimes, sort of out here in the periphery, people forget about ice machines. And we talked about bacteria being in ice and immunocompromised individuals sucking on those ice chips as a mode of transmission, not only for Legionella, but for most of these other gram-negative waterborne pathogens. So even though cold water goes into the machine, it warms up. The condenser and compressor inside the machine makes that water actually quite warm. They often have charcoal pre-filters, and those charcoal filters take out the disinfectant, so now there's not any residual disinfectant in the water inside the machine. Very, very high surface area. They're difficult to clean. When you clean these by the manufacturer's instructions, the manufacturer's instruction is not intended to disinfect. It's intended to clean. And so even if you followed that instruction, you could still have contaminated ice in ice machines. And then just a couple words about dialysis water. This is a highly regulated area. This is an example of an International Standards Organization standard, and it talks about water used for hemodialysis. So just a couple of things to say about that. Needs a lot of attention. So ANSI standard, AMI standards, the International Organization for Standardization. So again, lots of standards to make sure that the water going into the hemodialysis machine and then out the other side with contact with patients is not contaminated. But it happens, and it happens because it's a very complex process. This is an example of multimedia filter, water softeners, carbon tanks, reverse osmosis, deionization tanks, submicron filters. So it's very, very complicated, and oftentimes there are issues associated with dialysis. The other thing you have to think about when we deal with these waterborne pathogens, and then particularly with respect to Legionella, sometimes there's supplemental disinfectants that are added to the water to control the pathogens. Well, what do you do? Is that going to have an impact on your dialysis? And so this table just shows you the common disinfectant strategies: chlorine, monochloramine, chlorine dioxide, the presence of chlorite in the water because of chlorine dioxide, copper silver ionization. Most of the time, the carbon absorption filter removes them, or in the case of chlorite, the reverse osmosis does, and also for copper silver. Has the estimated EPA limits for those disinfectants, and what the ISO standard says should be in the dialysis water. So just keep that in mind, especially if monochloramine is used. You need to have high vigilance about the treatment of dialysis water. So I don't know if you're like me, a fan of Guardians of the Galaxies, but we can defeat waterborne pathogens together. And we do that through the facility risk assessment, identifying where Legionella and waterborne pathogens can grow and spread, develop a sampling plan that's logical and targeted for assessing the risk related to these various pathogens. And I say the rationale to assess the risk from your building water systems. And so you don't have to sample everywhere for these other waterborne pathogens. You need to consult with infection prevention. I would say at a minimum, you want to be doing ongoing testing for these pathogens in neonatal intensive care units and transplant units where those highly immunocompromised individuals are. And detecting these waterborne pathogens in water is beyond the hospital laboratory capability. And why do I say that? I say that because you might think, hey, hospital lab, I need to look for Burkholderia and Acinetobacter. Can you do that for me? And they'll say, sure, we can do that for you. We detect that in patients all the time. But here's the problem. The culture media designed to grow it from a patient inhibits flora in humans. The flora in the environment is very different, and the selective agents in that culture media to grow it from patients are virtually ineffective to inhibit the bacteria that are in water. So you need special media to detect waterborne pathogens, and if you're not using that special media, you are going to fail in their detection. So what are these special media to detect our friends, the waterborne pathogens? So there's a special media for Stenotrophomonas that has imipenem in it. There's a special media for detecting Pseudomonas aeruginosa from the environment. It's called MPAC media. There's a special media for Burkholderia called Burkholderia cepacia selective agar. And then special media, and we've helped to evaluate a highly selective media for detecting non-tuberculous mycobacteria in the environment. It's called RGM media. I'm going to show you an example of that in a minute. And then also a special media for Acinetobacter. So I want to show you, this is what it looks like when you're trying to detect non-tuberculous mycobacteria when you're using sort of standard media that's in the clinical lab. It's covered by bacteria that are not non-tuberculous mycobacteria. You can't find them because this media is growing all of them and not inhibiting them. Non-tuberculous mycobacteria is here, but only if you use a highly selective environmental media like RGM do you see them. So they were there, but they were missed by using that clinical media. So just to sort of wrap things up, we want to use a higher standard of water quality in healthcare. Even though water is everywhere and used to provide patient care, it needs to be a higher quality. Tap water is not sterile. Be careful using tap water. Well, I sort of talked a little bit about disinfection and controlling organisms and what do people do? And I just want to tell you that flushing your fixtures is not disinfection. Moving water through fixtures is a good idea, temporarily reduces the organisms coming through the fixture, but doesn't do anything to remove them from the biofilm up through the fixture. So it improves overall hygienic quality of the water, but Legionella and these other pathogens are within and throughout the system. Flushing alone will not eliminate them. So when do you consider disinfection, and what are the resources for you to look to? Well, in ASHRAE's Guideline 12-2020, the companion document to ASHRAE Standard 188 gives you some guidance. And so it says in the guideline, facilities where hot and cold water temperatures that are recommended for Legionella control can't be maintained. You can use the same philosophy for these other waterborne pathogens. And certainly if there's not a consistent and measurable amount of disinfectant residual throughout the system, consider disinfection, or talk to your water management consultant about that. I wanted to refer you to another one of our Wednesday webinar series on Legionella and stagnation by Michelle Prevost. Excellent presentation about what to do about Legionella and other pathogens and the effect of stagnation on there. So my last thing about disinfection and prevention of transmission, sometimes a physical barrier between the water and the patient is necessary. You can use point of use filters for that. And we're going to protect those neonates, whether it's Pseudomonas or Legionella. In the case of Legionella, there was a 22% mortality rate, and 72% of those pediatric cases were acquired from exposure to water in the healthcare facility. So get to work on your water safety and management plan. Refer to Standard 188 in the toolkit for the information. Now, the last thing I want to say about this is there's a new standard from ASSE, standard 1280, for certification of Legionella water safety and management personnel. Up until this standard was approved in April of 2020, there was nothing for you to measure the qualifications of people doing Legionella water management for you. And in this certification program is a whole section on waterborne pathogens. So these certified specialists have to know everything about Legionella and waterborne pathogens. So having someone certified to that ASSE standard 1280 is a good idea. It's a rigorous 3-day training. They have to pass a 100-question test, and that is a proctored exam, and they have to have a passing score of 80%. We just finished a 3-day training yesterday. The next one is October 18 through 20, and you can register, Google ASSE 1280 IAPMO training, and I'm proud that we provide that training with IAPMO. So here's a scary picture. This is a patient safety issue. While waterborne pathogens aren't zombies, we can protect people from these waterborne pathogens in great extent through education that tap water is a risk to patients, especially if sterile materials are near sinks. Tap water is used as a final rinse in equipment, and that those higher risk patients may be at greater risk and need a higher standard and quality of water. So as I talk about this, I realize that I create a lot of anxiety for people, and I never like to do that without providing the antidote. So we have Dr. Stout's chill pills, and they're for Legionella and waterborne pathogen anxiety. So if you're feeling anxious, just ring me. We'll send you some Dr. Stout's chill pills. They're mints, but sometimes it's nice to introduce the topic of controlling Legionella and waterborne pathogens with some humor, and sharing some chill pills with your facilities folks can do that. So just to conclude, testing for Legionella and waterborne pathogens is complicated. You need to use specialized media and an environmental laboratory like Special Pathogens Laboratory to do that. And what I want you to do more than anything is I want you to crash that party in the pipes. And I hope this lecture has helped you to do that. And I'm happy to take questions. And I really want you to stay safe out there.
All right. Thank you very much, Dr. Stout. This was great information. We do have one question. If anybody has questions in the meantime, we'll just please put them in the chat. There's that little chat icon toward the top, and we will. I'll just start reading them as they come in. And hold on. First question in is, should I really sample without knowing how much is too much of any of these bacteria? How much is too high?
We have a lot of information about that regarding Legionella, and a little bit less about that because we're sort of in the infancy of really working on using water management and monitoring for these other pathogens. So this is what I say about it. You don't want to just willy-nilly go out there and sample for these other pathogens. Legionella, we have a very clear path forward on how to do a sampling plan for Legionella. So what I usually advise, and what we put in our water management plans for people, is that, the places that I mentioned where there's extremely high risk of exposure and mortality if these organisms are present, and the risk of, if an infection occurs, that it being antibiotic resistant. So go to the neonatal intensive care unit. If you have a bone marrow transplant unit, one of the things that always drove me nuts about bone marrow transplant units is we filter the air for them through high efficiency filters, HEPA filters, because we worry about them being exposed to pathogens in the air. But then we hand them a glass of tap water to drink. Makes no sense. And so if you want to make sure that those individuals at highest risk are not exposed to these pathogens, those are areas where you could do a risk assessment. And then the other, and this is the role of infection prevention, they will be alerted to clusters of infections with these organisms like Burkholderia and Acinetobacter. They will say, okay, we've had an unusual number of these infections. Let's get the water management team together. Let's look at traditional infection prevention routes, but also should we be concerned about the water? And so that's where that collaboration between engineering and infection prevention is really important.
Excellent. So the next question in line kind of goes back to your last discussion, the first webinar we did. But you discussed the first draw of water in gooseneck faucets. Are there any studies on the first draw of water in showers? Are there any studies on hand shower or shower valve drain down?
So some of the research from Michelle Prevost and Emily Bedard, one of the publications that I showed you, and some of their other publications have looked at Pseudomonas in first draw water, and we and others have done so with Legionella. So whether it's a shower or a fixture, a faucet, it's an appurtenance, right? And the surface area is where the biofilm accumulates. And sometimes I do what I call the biofilm dance. It's like they're loosely adherent to the inside of the faucet. And when that first water comes through, those loosely adherent bacteria come out in that first draw of water. And for the most part, they like warmer temperatures. So first draw hot water almost universally has the highest count of bacteria in the fixture. And what you're asking, the question that you're asking is, are the patients or the occupants of my building exposed to this bacterium? And your best chance of answering that question with good sensitivity is first draw water out of that fixture, regardless of whether it's a shower or a faucet.
All right. And one is more around disinfection. So what is the disinfection efficiency of ozonating water?
So ozone is a very powerful disinfectant. So if I had my beaker and I put bubbled ozone into it, it's going to kill these bacteria very quickly. The problem that we and others have seen with applying ozone is that it's extremely reactive. It basically gets into the water and poof, disappears. And so what you have to do is have a confined area and keep adding it. So if you added it in a potable water system, it's going to disappear as it goes down through the pipes. Sometimes people have applied it to cooling towers, and usually it's most effective if there's multiple points of injection in the cooling tower so that there's adequate exposure and residual long enough to have an effect. So the problem with ozone is it doesn't maintain a residual because it's such a highly reactive chemistry.
All right. And then what about copper silver ionization or chlorine dioxide system for hospital?
So another time I could give you a whole lecture on the disinfectants that are available for controlling pathogens and Legionella in water. So whether it's monochloramine, chlorine, chlorine dioxide, copper silver ionization, there's lots of information in the literature about efficacy against Legionella. And in fact, our group over the years have evaluated either in the field or at the bench all of these disinfection technologies against Legionella. In the most recent field evaluation that we did with monochloramine, we actually looked and tested for these other pathogens over a more than a year period to ask the question, were they controlled as well, and was there any increase in them with the use of monochloramine? And I can tell you that there was no increase, and monochloramine did control Legionella and sort of hold non-tuberculous mycobacteria at bay. Now, I know that there's some publications about copper silver ionization, efficacy against some of these other pathogens, mostly in laboratory settings. And so I think the thing that I think we need is we need more prospective over time studies of all of these disinfectants looking at their effect in plumbing systems against these other pathogens. So in a beaker, the most resistant to any of these disinfectants is the non-tuberculous mycobacteria. Like I showed you in the slide, 100 to 300 times more resistant to chlorine, and chlorine is an effective disinfectant. So some of these, like NTMs, are a challenge in terms of chemical disinfection. And so sometimes a physical barrier like point of use filtration may be more effective with that kind of bacterium.
All right, great. This one is more about water temp. So what are the water temperatures that will confidently kill these organisms?
Well, I can tell you that they're too high to be practical in building water systems. So, for example, a colleague internationally showed that the temperature had to be above 130 degrees at the tap in order to control Legionella throughout a hospital water distribution system. So some people have tried to take 140-degree water to the tap and blend it. And I know many VA hospitals had done that and had some success against Legionella. Not much has been done in terms of field evaluations on temperature elevation for some of these other pathogens, but I would expect them to behave, apart from the non-tuberculous mycobacteria, I'd expect them to behave similarly. But the problem is scald risk. Many institutions, by code, are not allowed to have water delivered through the fixture above, say, 105 degrees. And then the confidence in some of these blending valves, they worry about check valves failing because in the old days they were brass and now they're plastic. And so there's a lot of concern about scald risk. And so it's very difficult. The takeaway message is it's very difficult to use temperature as your control measure.
All right. And then are there any studies that address the laboratory drains off-gassing through biofilm back into the patient rooms?
It's not so much off-gassing, but there's a number of publications that show that splash from the drains is a problem. And some of the publications talk about making sure that the spout of the faucet is offset from the drain so that it hits the basin and not the drain, because that direct hit at the drain causes splash, which could have these organisms in them. And in fact, one of the papers, they very cleverly put a fluorescent dye down into the drain and then ran the water and then turned the lights out and put the UV light on and showed splash 1 meter to 2 meters, many feet away from that sink. So that splash can occur to some great distance, thereby contaminating materials and possibly patients that are housed nearby. So that these are some of the engineering controls that can be done to minimize the exposure. And really, if you're doing any construction, should be in the pre-planning design phase. A lot of discussion between engineering and infection prevention about what kind of faucet do we want in this area, what kind of a relationship to the drain and offset and the shape of the sink, because all of those decisions are not just about the use of the fixture, it's about infection prevention. And so a lot is being done in that area.
Excellent. And then let's see, one last question here. Do water softeners contribute to cleaning any of the bacteria, or do they make it worse? Also, what about the non-salt softeners, like using deionization?
So I am a microbiologist / legionellologist, and so I'm not a water treatment professional. So take these things with a grain of salt. But I can tell you that outbreaks have been associated with growth of Legionella and possibly other organisms associated with softeners. So it can be a nidus for microbes, and depending on how it's used and configured. Can't really say too much about the particulars of those softeners. You have to consult with your water treatment provider. But you're on the right track. You're thinking about these areas where water is processed and can impact the water quality and safety of that water. There's some parts of the country that have to soften water. And so you just want to be on top of that in evaluating the presence and the potential for growth of these pathogens associated with those softeners.
Excellent. And then do you recommend testing water fountains used by visitors and staff?
The risk is very low there for two reasons. Most of the time the visitors and staff are not critically ill, right? They may have some risk factors, but most of the water fountains, drinking fountains today are standalone chilled units. That means the water is actually pretty cold. The only thing that you want to do, just like with ice machines on your annual or semi-annual preventive maintenance program, make sure that those charcoal filters that are used are actually exchanged out and that they aren't there for years and years, so that they're actually contributing to the pathogens in the water, and make sure that the temperature of that water is cold. That'll reduce risk.
All right. Thank you very, very much. Just in conclusion, I want to give a big thank you to Dr. Janet Stout. As a reminder, and I've got a lot of questions in the chat, a recording from today's webinar will be available soon, so keep a lookout for a follow-up email with information on how to view the recording. I do believe the PDF of the presentation will also be sent as well. This is part 2 of a part 3 series with Dr. Stout. The third webinar, mark your calendars, is on October 14th. So please keep an eye out for your email for more information, or follow Chicago Faucets and the Special Pathogens Laboratory on social media for more information. As a reminder, we have some fantastic giveaways of educational items from today's webinar. So look on social media pages September 1st for the next drawing. Given our giveaways for this webinar included 2 ASSE 1280 classes given by the SPL. As you saw, that's a great rigorous course if you want to learn more about this subject. 2 SPL Legidoc annual subscriptions. Legidoc plans are ASHRAE 180 and CMS compliant. Just customize your facility information, and Legidoc delivers a comprehensive plan in PDF format. Thank you again, and have a great day.
Thank you so much. Bye-bye.